Good day, everybody. This is Chris of the Ancient Scholar. I hope this video finds you all doing well. Happy New Year. All right, so we're going to go ahead and talk about the next finding or the next paradigm that is considered a STEMI equivalent as outlined in the 2022 ACC consensus statement. And this particular finding is something referred to as hyperacute T-wave morphology or hyperacute T-waves. And this is actually a really important component to identifying an OMI, an occlusion myocardial infarction, as opposed to STEMI. And I've talked in prior videos about the STEMI versus OMI paradigm and how the OMI paradigm is probably a better, broader, more inclusive paradigm we should be transitioning to. However, these particular videos that I'm working on are focused more on talking about the findings that are considered equivalent to STEMI as opposed to STEMI versus OMI and NOMI paradigms. So, hyperacute T waves are one of the four STEMI equivalents. We talked about De Winter T waves in the prior video. And just to emphasize yet again, anytime you have acute dynamic or hyperdynamic T-wave changes in a patient with signs and symptoms that suggest an acute coronary syndrome or myocardial ischemia, they should be taken very seriously. These are often some of the first things that you're going to see in the setting of ischemia, injury, and infarction are T-wave changes. We're going to be talking about some specific T-wave morphologies, but just T-wave changes in general, when you appreciate them in an acute or hyperacute context, should be quite concerning. All right, well, let's move on. All right, so let's just familiarize ourselves with what the normal T-wave looks like. So you've got your PQRS T complex. T-wave should follow the QRS complex. And generally, the QRS complexes are going to be much larger in proportion to the T wave. So think of the QRS complex as kind of a father figure, if you will, and the T wave as a child. And the child is generally going to be smaller than the parent, at least when you're talking about younger children. So here you have a T wave, and it is relatively small in comparison to the QRS complex. There aren't strict hard fast rules on this. It's a lot of gestalting at this point, but some things that can help you in identifying normal and abnormal T waves include the following. Typically, in the limb leads, so these would be leads 1, 2, and 3, the amplitude is going to be less than 5 millimeters. Remember, each little box on your ECG is 1 millimeter. So the amplitude should be generally less than 5 millimeters in limb leads, and it should be less than 10 millimeters in the precordial leads, V1 through V6 specifically. The T wave should have positive deflection, so that is deflection that goes above the isoelectric line. It deflects up in that direction, and you should appreciate this in every lead except V1 and AVR. And so this is a really good gestalting mechanism where when you look at a 12-lead ECG, you can just go to V1 and look at the T-wave morphology in V1. And normally in V1, the T-wave should be negatively deflected. And if you see a T-wave that is positively deflected in V1, regardless of what's going on with the patient, that automatically should cue you into thinking, okay, there is a T-wave anomaly, and there are some differentials that I need to be considering or I need to take into consideration. T-wave inversion in lead 3 may actually be a normal variant, so it is not as clear in V3. However, if whatever you see in lead 3 is a new change. So this is really helpful if you have an old ECG to compare, or serial 12-lead ECGs are going to be very important in anybody that has signs and symptoms suggesting an acute coronary syndrome. And if you see that the T wave morphology changes, say in lead 3 or any other lead for that matter, that should also cue you in to be thinking about acute problems such as ischemia, injury, and infarction. All right, so that's what the normal T wave looks like. And these are just some things to think about: the amplitude and positive versus negative deflection of the T wave. So what exactly are hyperacute T waves? Well, hyperacute T wave are T wave changes associated with the occlusion of a coronary artery. Strict criteria are a bit elusive, but gestalting is more a function of T wave size and morphology. And look at this. I don't know if you notice this, but my autocorrect. It's one of the unfortunate problems I find with Apple products is the autocorrect can really be problematic. But gestalting is more a function of T wave size and morphology, and you want to compare it to the preceding QRS, the R wave specifically, like we talked about in the last slide, where you kind of just look at it, gestalt it, and go, does this look like it is proportional to the QRS complex? And if it looks grossly out of proportion, that could be problematic. So generally speaking, hyperacute T waves are going to be broad, they're going to be asymmetric, and they're going to be peaked. So they're going to be broad, asymmetric, peaked T waves. So here you have a T wave that is, again, very large, very tall, and very wide in comparison to the preceding QRS complex. And you notice that is asymmetric. You have this sloping here that is different than the sloping on the right-hand side. And so this is an asymmetrical T wave. There are other things that can cause widened, broad, peaked T waves, but the morphology of those things can be different. They think of something like hyperkalemia, whereas hyperkalemia tends to produce more of a tinted peaked T wave, something that looks like that. So the morphology is actually very important. But this is morphologically what we see with hyperacute T waves. Now, with that in mind, there are some differentials you want to think about that can cause alterations of T wave morphology and may masquerade as a hyperacute T wave. And these are some of the more common ones, and this is not a complete exhaustive list, but these are some more of the common ones that you want to be thinking about when you see T wave changes. So left ventricular hypertrophy, or LVH, and just ventricular hypertrophy in general, right? Ventricular hypertrophy can cause some changes as well. Hyperkalemia is a big one, and hyperkalemia is kind of a great imitator when it comes to T wave morphology and ST segment changes. And it is a critical differential that you don't want to miss, because if untreated, can lead to substantial morbidity and mortality. So history that suggests hyperkalemia is incredibly crucial to ascertain, or to get a hold of, if you will. Bundle branch blocks are also notorious for causing ST changes and T wave morphology changes, specifically left bundle branch blocks, but right bundle branches can do it as well. Increased intracranial pressure. This can be associated with T wave changes as well. Severe hypothermia can also cause T wave changes. Pulmonary emboli, particularly pulmonary emboli that cause a lot of strain on the right side of the heart. You can get some characteristic ECG changes associated with PEs, and of course PEs can also present with chest pain, dyspnea, and so on. Being very young, you can have different patterns associated with young generally healthy people, such as persistent juvenile T-wave patterns and benign early repolarization, and variance angina like Prinzmetal's angina, for example, can also cause hyperacute T-wave morphological changes. So whenever you see these changes, you also want to think about these differentials and rule them in and rule them out to the best of your abilities. All right, so here's just some examples of hyperacute T waves. So here we look at this 12-lead ECG, and the way that I look at ECGs is I just remember the saying, I see all leads. And I is the inferior wall of the left ventricle, the right side of the heart, the right coronary artery, and though that includes, so I is inferior, that includes leads 2, 3, and augmented vector front or foot. And so that's where I tend to start. So I'll start at the inferior. 2, 3 AVF, 2 looks okay. We've got some ST depression. So T waves, the J point is depressed below the baseline. That may be indicative of something. And whenever you see depression, another thing you want to think about is, could this be reciprocal to elevation in other leads? Could this be a reciprocal change? All right, so that's I. And then C, the septum, that includes leads V1 and V2, so the septal wall. So we're looking at the left anterior descending artery here, and then all the anterior wall of the left ventricle, also the LAD, V3, and V4. And so that's where I move to next. I look at inferior, and then I look at the septal and anterior leads. And you notice we've got a slight bit of ST elevation here that might not by itself meet criteria, and you also see you've got maybe a little bit of elevation here and here as well, and you can have a discussion as to whether that meets classic STEMI criteria or not, but it is very obvious that you've got a very wide, a very tall, and you have an asymmetric T wave there, and it is wide, tall, peaked when compared to the preceding QRS complex. And so you are in fact looking at hyperacute T waves here in the precordial leads. And that should be a noteworthy finding. And then finally we move on to leads. The lateral wall of the left ventricle, this is the circumflex artery, and these include V5, V6, 1, and AVL, augmented vector left. And you see here I've got just a little bit of elevation in AVL. By itself probably would not meet classical STEMI criteria. But here's the interesting thing. Without the hyperacute T waves, if I just saw that little bit of elevation there, there would be something in this 12 lead that would push me to think about an OMI, an occlusion myocardial infarction, and push me to suggest this patient go to the cath lab. And that is this depression here in the inferior leads. This is a powerful finding. Even though I don't have classic STEMI criteria here, we know that the inferior leads are reciprocal to the high lateral leads, 1 and AVL specifically. And so if I see any elevation in the high lateral leads, and I see that married to depression in the inferior leads, that is powerful evidence that I am in fact dealing with a STEMI equivalent. What we're actually looking at here is somebody who has some anteroseptal changes as well as some lateral changes. And this, just based on the hyperacute T waves, would meet STEMI equivalent criteria, assuming the patient has signs and symptoms suggesting an acute coronary syndrome. we could talk about what exactly we can see in this 12 lead in more detail, but that's beyond the scope of this specific video. All right, and let's just look at one more example, and this is maybe a bit more of a subtle example. So again, let's start with the inferior 2, 3 AVF, and you notice we have some depression, maybe not so much in AVF, a little bit in AVF, but certainly we've got some depression, T-wave inversion lead 3. Could that be ischemia? Could that be a reciprocal change? All right, then let's move on to the anteroseptal leads, V1, V2, V3, and V4. And this is much more subtle than the last 12 lead ECG. And if you notice, the T wave is upright in V1, so that automatically tells me something funny is going on. I have abnormal T wave morphology because it should not be upright in V1. All right, but we also notice that these T waves are pretty wide and pretty tall in comparison to the preceding QRS complexes, and you have this asymmetry to them. So we are in fact looking at hyperacute T waves. This is much more subtle than the last 12 lead ECG, but these are hyperacute T waves nonetheless. Now if I move on further to the lateral leads, V5, V6, 1, and AVL, again, I have a slight bit of ST elevation there. By itself, that would not meet STEMI criteria, but this is in the high lateral wall, and I have this depression here in lead 3 specifically, maybe a little bit in AVF, and that is almost certainly reciprocal, and that is more powerful evidence that we are in fact dealing with a STEMI equivalent. And then you marry that to these hyperacute T waves, and this is someone who needs to go urgently to the cath lab, and this is somebody who would not necessarily meet your more typical or your more standard STEMI criteria. It's close, it's kind of borderline, but a lot of people classically could look at this and say, hey, this doesn't meet criteria. Let's sit on this patient, let's get some cardiac enzymes, let's maybe do some serial 12 leads, maybe admit them to CCU, maybe then go to the cath lab and in a day or so, treat this more like an in-STEMI, if you will. When in fact this is somebody who needs to go emergently to the cath lab. And in fact, what we're seeing here is something referred to as the South African flag sign, and that is beyond the scope of this specific video, but it is a finding of elevation and depression in certain leads that looks kind of like the South African flag, and it suggests that you have occlusion of a branch of the left anterior descending artery, specifically the diagonal or the D1 branch of the LAD, that is causing this high lateral myocardial infarction. And this is somebody, again, who needs to go emergently to the cath lab. And that is to say that all of what I just mentioned is a little beyond the scope of this video, and the point of this video really is being able to identify these hyperacute T waves and these T wave anomalies. All right, and that concludes this video. These are some of my references. The first 3 references all come from Life in the Fast Lane. This is an incredible, not only ECG library, but an incredible learning and teaching aid. And it is primarily run by Mr. Burns and Mr. Butner, doctors E. Burns and R. Butner. The 4th reference is a high-yield breakdown of the 2022 ACC consensus statement that focuses on the primary findings that are now considered STEMI equivalents, and so I wanted to include that as well. All right, everyone. Hopefully this video was helpful, and hopefully you get something from it. And I hope you have a great new year, and hopefully we'll see you in the next video. Take care, everyone. Bye-bye.